and it's wonderful to see so many people even after lunchtime. I will be talking just basic of this biometry. As we all know, freedom from glass after cataract surgery or cataract refractive surgery is a newer term, and we all are bound to give them 100% to the patients. So first thing in giving 100% to the patient is the correct IOL power. And for correct IOL power, first thing is to do a correct A scan. So I will be talking just basic about the A scan. So in biometry, if you see, the first thing is axial length, and then your corneal power, and then the effective lens position, which is very important nowadays because that causes a lot of bearing on the IOL power. So if you see in the history, Sir Gerard Ledley has implanted the IOL and the refractive surface was 20 diopters. So at that time biometry was not there, and if you put 20 diopters difference, the patient will be blind on. So desired result, now we have emmetropia. So effective lens position is a distance from the vertex of the cornea to the lens plane in a visual axis, and from visual axis to the macula is a factor y, and combining two you get the axial length. So this is very important because a small error in axial length give a very large problems in IOL power, because if you see 1 millimeter difference will cause 2.5 diopter changes in IOL power in a normal patients. But if you go in high myop or very large eye, it will reduce to 1.75. And if you go in a very hypermetrop eye or very small eye, it will be bigger, even more bigger. That is 3.75. So greater care must be taken for measurement of shorter eye, and always try to measure both eye. So coming to the method, we have now optical method, which is the gold standard now, but still in lot of cases you cannot do an optical, and the cost is one of the factor which everybody cannot buy. So now we come back to the ultrasound. You have a two method. You can do a applanation or you can do a immersion. Immersion is superior to applanation. We'll go through that. So first, basics of ultrasound. A transducer is used to send ultrasound pulse, usually 8 to 10 megahertz, to create a sound beam which passes through the eye. The sound beam is reflected back at the interface of changing tissue density like anterior capsule, posterior capsule, retina and sclera. These echoes are displayed as a vertical spice which is rising from the base. The time taken from the sound wave to return back is converted in distance. Using the velocity of sound through the various tissue, we can calculate the distance. So this is important to know, the velocities of sound, because nowadays all the machines will have a fixed already. They will calculate like phakic eyes will have 1555. Similarly, aphakic eye and every. So we should know because the axial length will differ. If it is not proper, it may be high, it may be low, or it will not be proper. So we should know at least this. So these are the various machines. We at our center use this Contel machine, and all machines are good. The only thing is that we have to practice more. The worst part of this biometry is that most of us do not do ourselves. We train our staff to do that. So there is a catch. So in applanation, what we do, it is a contact method. So probe come in contact of the cornea, and if you are not careful, if you press slightly, the reading will be lesser than the required reading. So this is what you can see. The probe is just touching to the cornea, and the beam is from corneal vertex to the macula. It should not align to the disc, or it should not align to the other place. So this, you will get the reading like this. You will get a vertical spice, which is the anterior capsule, then the posterior capsule, then retina and sclera, and then dying spine of orbital fans. This is a small video demonstration how to do. Few things are important in this. After putting the anesthetic eye drops, you should make the patient look straight and make the head position should be proper. And you see that she's stabilizing the probe with another finger so that it do not overpress over the eye. And once you touch the cornea, these machines are automated. They will start taking the reading, and usually take 10 readings and then average it to give you axial length. So you have both manual mode, you have both an automated mode. Manual mode, in case you are not able to take the readings with the automated mode, you can go to the manual mode. Again, you have to see the scan. When you are doing a manual mode, you have to see the scan and then freeze. So in normal scan in a phakic eye, you have 4 spikes from the cornea, anterior lens, posterior lens, and the retina. So axial length is from the corneal spike to the retinal spike. Gain has to be changed depending on the density of the cataract, because the echo may cause change in the axial length again. So we have to increase the gain if the cataract is dense or hard. And if you are doing a manual, minimum 3 readings should be taken, and then make it to average it from that 3. So always measure both eye. The difference of 0.3 between 2 eye should always give you a suspect and re-measure it. Some errors when you give the spike, this figure you can see this spike is smaller. So that means the lens, the beam is not passing from the center of the lens. So the posterior spike has become smaller. So similarly in this, if you see the absence of a scleral spike from the orbital spike and orbital fat, beam is not aligned with the macula, it is aligned with basically the optic nerve. So you will not get the scleral spike and the orbital fat spike. So in this, if you can see, the beam is not perpendicular to the macula, the retinal spike will not rise sharply. It will have the advantage of applanation is it is easier to learn, quicker to perform, and no additional space you can do in the sitting position in your OPD itself. Now coming to the immersion. Immersion is superior to the contact method because it do not touch the cornea. So you do not get that 0.2 millimeter, with a lot of study has shown that shortening occurs in contact method. The patient is supine or in a reclining chair. Again, the local anesthetics you have to use. There you have a 3 types of cell: Henson cells, Prager cell, and Kohn cells. These cells are used over the sclera, and it is filled with the fluid. You can use it's better to use BSS or normal BSS fluid. And if you are using a Prager or Kohn cells, this is tight fit, so you can easily use BSS in that. While the other one you have to use high density like methyl cellulose. Always avoid to air inside, because it will change the velocity of the sound. So these are the various cells. This here you can see this is at a distance. This is from 2 to 8 millimeter from the cornea. The patient has to your head should be straight, and patient should fix straight towards the ceiling, or you can give a fixating target with the hand. And after fixing the shell inside the eye, just fill it with the fluid. This probe we can adjust. This probe you can adjust. If the beam is not correct, you can adjust. Now the beam is coming, and you can see this will take almost 10 reading and make it average out of that. So ultrasound probe is inserted into the this already we have seen. So this is the difference between the contact and immersion. Here you have got 2 extra spike. This is from the anterior surface of the cornea and the posterior surface of the cornea. The advantage is no, in this, as we have already discussed, no applanation is required. The objective alignment is better, easier to alignment due to the corneal spikes are there, and the optimal result you get with the immersion. It is almost comparable to your optical methods. This is important because we are using the cell inside the eye, so you should have a sterilization, a strict sterilization. So CDC criteria, thorough soaking of the cell is and probe in a beaker with alcohol or hydrogen peroxide, or we can just ETO it. But if you have more number of patients, you cannot ETO a lot of things, so you can just soak it and make it dry. That is very important because these alcohols are toxic to the epithelium. So dry it and flush it with BSS properly. Then a remeasurement is required if it is more than 3 millimeter difference in 2 eye, if axial length is less or axial length is very high, and if it doesn't correlate with the spectacle refraction. So too short and too long. Too short if corneal you are compressing the cornea as we does in the contact method. Vitreous opacities, RDs, all this can give a false spike which can give you a short reading. And if the velocity is not important, velocity can cause even longer or shorter readings. And if you are doing a contact method and you are bringing the probe back, some people try to do to reduce the pressure, then the fluid interface is there, and that will give false large reading in these cases. I think cratometry, I think that it will covered by.
No, can cover it.
Okay. So the next thing in this is cratometry. So, keratometry, we have a manual keratometer, we have automated keratometer. Most of us are now using the automated keratometer, which is more easy and nowadays it is reliable also. But if you have to do a manual keratometry, then it is important to ask the patient not to put any eye drops inside the eye. And then if they are using contact lens, we should discontinue the contact lens at least 2 weeks before, because this will change the tear film and the mayers will not be good. So you will get the 3 mayers in that, and you have to align this plus with another plus and minus with the minus. And this gives the center 3 millimeter of the corneal diameter. So automated we have already seen, so shorter, it has a very simple things anybody can do, and the handheld can be used in cases of like uncooperative patients. Now one question, how many people are doing biometry by themselves? Wow, it's great. Because most of the institute-based practice or like our optometrists are, but that is like Dr. Holiday has done a study about that. If you train your staff, it gives equally good result as you do. Thank you.